virtual clinical trials is a thing now too. You can do all kinds of stuff remotely. Look into it. That's actually the next forefront, is starting to do virtual clinical trials to increase the access to trials for people who live in remote places that aren't near major academic centers. And they're starting to decentralize the way they do trials and stuff. It's pretty cool.
I'm obsessed with that. Welcome to Target Cancer Podcast. My name is Dr. Juneja. I'm a triple-boarded hematologist, medical oncologist, and an internist, and we are going to talk about something that I'm so excited about because I actually spent about 10 minutes before this podcast getting to know her. Dr. Purdy is someone that is extraordinarily accomplished, and there's one thing that's been her biggest goal, and that is basically enabling access so that people can get good care and feel heard and basically understand their health so they can be empowered and then do the best things possible. She's done it in a gazillion different ways, and yes, that's the exact number, and it's been from different things like virtual healthcare visits. She learned a lot and was actually able to enable people to get care in Ukraine during the war, during COVID. Welcome to the podcast. What did I miss?
I think you hit the high points. I mean, there's so much to talk about. There really is. But the point is, at the end of the day, we all want the same thing, right? More access, better care, reaching people everywhere, and increasing the doctor's capacity to take care of people. Who doesn't want that, right? So I call myself, I'm called America's favorite doctor. And the reason why is because I'm licensed in all 50 states. And I have companies and clients and patients and people that I work with, businesses all across the country, and literally every single human in the United States of all ages, because I'm family medicine, so, end to end, they can all be my patients. And so I'm excited to be here. Thanks for having me.
Of course. I think it's awesome. I read that. I was like, licensed in all 50 states. That's absolutely wild. I did have a question, though, right before we start. If you're licensed in the states and you're virtual, say like the cancer patients were kind of like tuning in to be able to get something with mental health or kind of like the stuff that's more collateral, there's just a huge injustice. There's not a lot of support for the things outside of direct treatment when it comes to a typical, community oncology clinic. Are there like narcotic, prescriptions, or sometimes a lot of the, THC products that really help with cancer-related nausea and stuff? Can you do that stuff virtually if you are boarded, or you also have to have DEAs like in different places? How does that work?
Sort of. So as you know, that's actually, so it's DEA, and then also the states have their own
policies, right?
rules and legislations, and narcotics are the absolute hardest thing to prescribe through virtual health. And frankly, it's because a lot of people have done the wrong thing and they abuse the privilege and they kind of messed it up for the rest of us. THC, however, listen up, people who have cancer and want THC, there are hundreds, maybe even more than that, of medical marijuana telehealth companies, like a gazillion.
There you go.
Is that what you said? The actual number. So many. Within the last 2 years, that has been, I would say, that and mental health have been the two areas that have exploded, like Green Care Docs, medical cards, Nug MD. Like there's so many. I don't even, MMJ, Rex was another one. Tons of companies. So you can get all of that, but it depends on the state. If it's a controlled substance, then you have to have a DEA there. Well, technically you don't, because the HHS waiver is still in effect from the pandemic for the next few months. But I go ahead and tell people, just get the DEA number, because if you're treating these patients and then they take away the waiver, then that doesn't help anybody. So you can do it, but you do have to have the DEA number, unless it's not a controlled substance, and then you don't, right?
That makes sense.
For some states, it's not.
That makes sense.
Mm-hmm.
And the one really cool thing about like pain is that there's so many, and I really need its own episode on, kind of interventions that you can do. Of course, you can kind of like block nerves, right, that perceive the pain. If you have like something that's like in the bone and compressing a certain place, or constantly just transmitting that signal, pain makes sense evolutionarily. It's like you need to know that something's there so you can either, pull that, arrowhead out or whatever, or not step on something. But if you know it's going to be there, then it doesn't make a lot of sense to have that sensory constantly. And you can inject stuff, at the nerve root. And now they have these, what I call intrathecal pain pumps. So basically right at that site of disease. So say like you have some, cancer spots in your hip and it's constantly hurting, you can actually place it inside the thecal sac. And then on that pump, you're able to deliver that kind of opioid or that kind of receptor related analgesic at the actual place where it's being conducted, the pain, so that your systemic toxicities, right, or at least the systemic circulation is actually really minimal because the CNS system, the spinal cord and the brain, is all kind of a sanctuary. And so you don't have to kind of take it by mouth or get it IV to where you have these high concentrations causing constipation and dry mouth and all these other problems, and instead achieve the same thing. So there's a whole bunch of stuff out there that, if anyone's listening and they're like, because, like you said, narcotics are a very big problem, like really anything good in life, right? If it's abused, it becomes a bad thing, but it also like serves a place. And I think sometimes it's hard. Like I've seen a lot of people on my social media comment like, I have very real pain. And even though I'm young and I look okay, I have cancer in my bones, there are all kinds of strategies where you can see a pain specialist. So that's one point. And the second point is, with THC and marijuana that we were talking about, I mean, Cleveland Clinic, Mayo, I believe, and several centers have been looking to see the role. And part of the reason is because it can really be kind of helpful when it comes to like pain, nausea, appetite, and it's continuing to being studied with relatively low side effect profiles. So it's something that, again, also probably needs its own episode. And if I had it my way, I'd bring you back on board for that. We would do some reading together. But I think it's so neat that you're boarded in all those places because, again, you really are big on access. And one of the biggest things that I'm very particular about, and it's with bias, obviously, but it's on cancer screening. Because a lot of people say, like, why aren't we able to catch cancer sooner? Why are they advanced? And a lot of people also say, like, I don't want to get screened because if I saw what cancer did to, my loved one, it was very difficult. And I would rather not know about the cancer and kind of just like, not go through those treatments. And there's several points there, and I need to stop talking because I want to hear you talk. And that's what I'm so excited about. But the couple of points are, cancer was treated very differently even 20 or 30 years ago. It was a lot of intense cytotoxic chemotherapies and toxicities and shotgun approaches, and now we have all kinds of targeted stuff. But secondly, and more importantly, that I would love to hear your thoughts on, is screening is not necessarily to say, oh yeah, I'm sorry, you got a really bad diagnosis and life doesn't look good. It's really to, in a lot of circumstances, like pap smears and stuff, to catch cancers before they become a big problem and go stage 4 and spread, right? Because a lot of times you can snip out a stage 1 colon or something sketchy on a pap smear or on a mammogram and actually avoid mortality and stage 4 stuff. And I'm sure you're able to do that in this like virtual setting to be able to arrange to make sure they get their screening. Why? Because screening, that's standard of care, at least first line recommended, usually is approved by everything, right?
Yes, that's what I tell patients about screening, because I'm a primary care doctor, family medicine, right? So like the first line of
Right.
defense when it comes to screening. What I tell them is that's the whole point of a screening test. The point of a screening test means that anybody who qualifies, right, whether that's somebody over the age of 50 or women over the age of 40 or whatever the guidelines are right now, every 3 to 5 years, if you have a cervix, the point of screening is not to tell everybody they have stage 4 cancer and have 3 months to live. The
Yes.
point is that we've identified that if we start looking at a certain age, we can catch the thing just like anything else, an infection, right? An injury. You catch these things early so that you can do something about it. And if there was nothing we could do about it, we wouldn't have the screening test. That's the whole
Ooh, I
point.
love that
We
second
screen for
point.
things that we can do something about,
Yes, I
right?
love that second point. I never thought of it like that. That's true. We wouldn't just do it just to say that because it actually helps. That's why they say like pap smears and
Yeah.
cervical cancer really shouldn't be a thing because it gives you a big lead time before it becomes cancer. Like all those terms, like little atypia or dysplasia or CIN1, like all of those things are just different variants of okay, it's not cancer yet, but we know what the lead time and the intervals are. And the same with colonoscopies. We know it's 3 years or 5 years or 10 years based on no polyps. Is it a nice little, benign adenoma to polyp? Is it a tubulovillous adenoma, which, has about an 8% chance and within 5 years? That's where these numbers are coming from. But any test is scary, right? I remember one of my friends wanted me to go get like HIV tested with them because they were worried about stuff in college as freshmen. And I was actually nervous about the results. And at that point, had no reason to be literally, but it's still scary, right? Just even though I had no
Yeah.
logical reason that it could be just given where I was at that place in my life. So it's definitely appreciable how scary it is. But most people obviously will get good news. And it's something that, like, as far as the screening goes, that can still be arranged, right? So if somebody went to you for their primary care because it's hard to access, or their primary doctor is just oversaturated, taking care of really sick people, 60 patients a day. Say they wanted some more face-to-face time, they can still have the screening part that doctor would have done to arrange done this way if they have basically any kind of insurance if it's a standard screening, correct?
Yes, or cash pay. I mean, some people actually would rather just pay for it in cash because how many times do you hear people say, I love my insurance company. It's really cheap and they pay for everything. I mean, that's just like, it's not really the reality for a lot of people, but you can still get all of that online, every bit of
Yeah.
it. And it's worth saying too, it's important to get repeat screenings. There's a reason why the guidelines say get this done every 5 years or get this done every 10 years. Because during that amount of time, you being a human, being alive in the age that you are and the gender that you may be, you're at risk of still developing cancer, even if it was negative before. So it's important to also do, follow your doctor's advice and get your follow-on screenings too. It is so preventable. And nowadays, I mean, there's even, I don't, we didn't talk about this, so I don't know what your opinion on it is, but there are some more cutting edge, like cell-free DNA
Yeah.
blood tests and like other screens like that people can pay cash for. And some people even ask for tumor markers, which this is America, you're allowed to do that. If you want to pay for tumor markers, you can do that. And so there's a lot that you can do in this country from the comfort of your own home and still be getting healthcare.
Right. And that's, I mean, that's a good point
Mm-hmm.
because a lot of times it does make sense. There's a lot of models where people are having, even if it's not virtually, like they pay a cash amount, like, a year or a month, and they're able to basically have kind of more directed access to somebody that doesn't have a high volume in person or just pay cash for someone online. But I don't want anyone to think, and if I understand it correctly, you can still pay for cash. A lot of times it does make sense to have the virtual visit. But if you have insurance, then the screening at least, like you don't have to worry about paying cash for that because you paid for a virtual visit. It's indicated, you meet the guidelines, so the bare minimum, you're able to then get that covered with whatever you do, whatever you have. It's not good or bad. If it's Medicare, standard kind of grade A, category one recommendation, that will be covered despite the fact that you used obviously like cash pay for somebody online. So that's straightforward. It's amazing, and I hope that kind of encourages people to be able to do it. I love another brilliant point you said that I never said it so clearly, but you're like, as you get older, like it can happen again. It's not like, oh, I'm good by far. And I did a little TikTok on this where I said like, what is the biggest factor for like cancer? And it was like smoking and red meats and sugar and age. And I was like, which one is it? It's obviously age. Like nothing,
Age,
nothing.
age,
Yes, age, age, age. And when you called me middle aged and old before we started this thing. But
especially for men. Sorry, guys. If you all live enough, every one of y'all's getting prostate
yeah,
cancer.
yeah,
So, I
that's a
mean,
thing.
is that still the statistic? Has anything changed since
Everybody.
I
It's
got
a
out of
yeah, no.
school?
But I mean, they say if you live
All
long
of
enough.
them.
But yeah, so I mean, to your exact point, it's the errors that happen over time, and obviously, if you're 90 years old, you have more errors, or middle age, like you called me, and I have more errors than I did when I was 15, and so therefore, that's the thing you worry about. So that's on screening. And then the second thing that I was curious about, and this is really big, we touched on it, but there is a severely, it's basically unjust availability of mental health and kind of like emotional, psychological things in general, of course, in this country, but especially underserved. I had Cody Christian, the actor, and he got very real about it. He's like, it's hard to find stuff for my mom when she was going through that stuff, but there was almost nothing other than cash pay, and thank goodness I had the means that for all the sons and daughters of parents that are having it, where you can find something available without paying a lot of money. But that was before virtual, right? Because obviously virtual, because things are available, it's a lot more cost effective than a private in-house brick and mortar shop in town. What, and I know you are a consultant or kind of like a advisor guru for so many different like virtual like platforms. It's not just preventative family care. You've done him and hers or hims and all the things that I've seen all over everywhere. That's something that's available, right? That somebody that needs that kind of like support can still have a very real call like this. And I feel like I know you already so well in that first 10 minutes before we chatted. They can still achieve this and have these regular intervals. And if they're having difficulty finding someone at home, it may not be something covered with insurance. Or let's start there. Can you have psychological, I guess, help or mental health help and it ever be covered with insurance if it's virtual?
Yes, it depends on the insurance carrier. It really does. It's just as complex as it is in person. Of course, you have to have a certain length and you have to have a certain modality, meaning like this on a video, you have to have your diagnosis codes, you have to qualify for the diagnosis, the screening, the time. There's so many factors, but yes, there are companies out there that are using insurance to do not only one time, but actually the exact same model that you get in person, long term, repeatable, with prescriptions if necessary. And they'll do like psychologists or LCSW, or whatever sort of type of therapist that you need, yes, I would say neck and neck with the marijuana industry. That's been the biggest thing that I've seen boom in digital medicine, especially since the pandemic, when
A lot of people
forget about
needed
it. I
it.
mean, there was no option. Well, we needed it, and you couldn't go anywhere.
Yeah, that too.
The therapist, brick and mortar facility wasn't critical enough in a
Right.
lot of places, unfortunately, for those facilities to be open.
Yeah. Is there a quick way, other than just kind of like, I guess, being on hold for a long time with your insurance company, to be able to see if you have any of those things in your insurance? Or is it just like, is there like a little website where you can go? Probably not. They try to make it difficult usually, right?
You can try. So actually, you can. Some of the really big ones like Teladoc and MD Live, they are actually, and I think maybe even Amwell, they have partnerships and are in network with some of the big, like Cigna, I think, if I
Oh,
remember correctly, Optum. One of those big insurance companies owns MD Live now, and so we're really starting to see that more often than we used to. So
good.
contacting the insurance company is actually a great place to start, because the insurance companies are starting to realize that this is, I hate to say it, but it is more money for them,
Right.
right? They can get reimbursed for it. Their patients are using it. And I hate to even say it like this, but if that's more money for them. So
No, I mean,
there's incentive
I'm
for
glad you
them
said
to do
that.
it.
Yeah, because one of the things that I learned, in 3 short years of being out of fellowship is like at first you learn like, oh, this is like it seems like it's money driven or this, that, and the other. And I think at first, the first year was a little difficult for me to kind of like understand because you obviously sign up for something 14 years before an oncologist or 12 and same amount of time, but you did a whole bunch of stuff with military and army stuff. But you would have no idea to appreciate like what it's like, right, when you're signing up and you get out there and you hopefully have made it through those 14 years just hanging your hat on being able to help people, and you realize that you are in a large part, unless you're an academic place, which actually still applies. It is basically once you accept that, like, okay, this is what their primary incentive is, it's for profit, or this is for how they make money, whatever, it actually somehow makes you a better physician and a better kind of facilitator, because then you like accept it for what it is, and it doesn't mean like then you can use the system and help navigate and figure all that stuff out. And it's funny, I share that sometimes with non-medical friends, and again, the fact that you just said something spot on, it's never a bad thing to realize why, if it helps the greater good. And so with that, with pharma companies, on TikTok, a lot of times people say, "Oh, you're an oncologist. It's just to help pharma make money." And I'm like, "You're right. Pharma's making money. I'm not making money because that's pharma." But at the same time, pharma's trying to make money, but at least the way they're trying to do it actually helps a lot of people, and a lot of times has therapeutics that are so much more forgiving and kind of in line with quality of life than kind of the traditional cytotoxic chemos, which will always have a role because they're very effective. But that's interesting. That's good to
Inventing
know.
new drugs is expensive, right?
Yes.
Scientists, laboratories,
Yes.
inventing
Equipment.
smart
Inventing.
brains, that stuff costs
Inventing is
money.
expensive. Like that's the
Inventing's
phrase.
expensive. I can't invent new drugs. Can you? Oh, you
No.
probably can. You're probably smart enough to do that, but I am not. So I'm glad that they have the money to pay for the big brains to
Exactly.
invent new drugs, right?
Yes. And I love that you said that because I had a really good podcast with Greg Simon, who was the first executive director of Cancer Moonshot. He's actually devising a system. One, he breaks down why they're so expensive, and it's more the retro cost of the hundreds of millions to see if it works out. But two, he's devising an entire system where you can kind of hedge basically against certain medications, and the own pharma company can, because when they see that something is coming to basically replace it, they don't have to increase the prices to justify stuff. You hedge it against yourself, you make it up, and then therefore the costs are less for everybody else. It goes back to that kind of accepting that like this is what it is. Like money, companies generally don't want to lose money, but then if you find a system to where they can then not lose as much money, it actually helps the cost of everybody. But I digress. So basically, it's available. It sounds like there's a whole bunch of different ways to do it. We'll probably put some links on this podcast. And I want everybody, of course, to go to your website, which I checked out. It says coming soon, but you just have to Google your name to be able to see like all the different resources. I just love that your like stuff is all about access, and you're just doing it so glamorously. But it's neat. Where can people find you before I ask you the next question? Because I want to make sure that they can kind of basically soak up the rewards and nutrients that you're fertilizing to help a very over-dried system when it comes to preventative care and access.
Please do. There's so much more to come. We have a really long, I would say, pipeline and runway of things we're going to talk about and stuff we're going to share with the public to help them understand why they must demand increased access to care through telehealth. Because the only way that things are going to change is if the people with the power make it change, and not me, it's not you. We don't really have the power. It's the citizens and the people of America that have the power. So my job is to educate so that they can then demand change. But I do have a website. I think the web design team met today. I'm hoping we're going to see that come to fruition soon. But it is, Dr. Laura Purdy, drlaurapurdy.com. I have an Instagram too. I'm on LinkedIn too. You're right. I'm all over the internet. You can find me. I'm not hard to find. People do it every day.
You can really start in any capacity, right? Like things can start on literally like a county, as you all call it. So we have parishes down in Louisiana, but as a parish or as a county, like you can start at that level. You can start like in city, mayor's office, governor's office. Like it's, I've been also very humbled to learn in 3 years how easily policy, I say easy, but policy can be very like, manageable and changed, and it can start from anybody. That's the whole concept. And maybe I sound ignorant because you're like, yeah, bro, that's what elections and all this stuff is for. But it can really start at a state level. You don't have to wait for the federal stuff to change, and then it can go to federal when people are taking suit. So that's a very good point. To be able to like hopefully kind of stimulate and say, hey, this is what we need. We need access. If you're listening to this and you're like, I get 2 seconds with my like primary doctor, and I wish I could ask more questions or ask why like my labs aren't making sense, or they say everything's fine, but there's a whole bunch of red and it's supposed to be black. If you're feeling those kind of things, then that's where like a virtual, like if your community's saturated, it's not that they're unthoughtful. It's that a lot of people have a lot of needs. They have A1C diabetes of 12. And so a lot of times communities are just oversaturated with taking people that are very, more or less acutely ill, and that preventative care gets lost, not because they're not caring, but because we have a shortage of doctors. And it sounds like that's a really good candidate to be able to say like, hey, let me break this stuff down for me. What do I eat? I just want to know what to eat. They say these general 3 things, but I want to learn more. You can do all that stuff virtually.
Yeah, you definitely can. Anything that you want to do. Actually, one thing that you'll probably be really excited about, or maybe you won't, but I bet you will because you do cancer, is virtual clinical trials is a thing now too. You can do all kinds of stuff remotely. Look into it. That's actually the next forefront, is starting to do virtual clinical trials to increase the access to trials for people who live in remote places that aren't near major academic centers. And they're starting to decentralize the way they do trials and stuff. It's pretty cool.
Who is?
There's several companies. I can look them up and tell you.
I'm obsessed with that. Yeah, like I mean, we work, so XCures is a company I met for that same reason. I was like, I try to go to that fourth, fifth, like anything that makes sense line, but I'm like, I know there's stuff that I can't access, but I don't want, or my patient can't fly to MD Anderson, which is kind of close, and then Tulane, and then Memorial Sloan. I'm like, how is there, with all the technology in the world, not a way where I can just query it all just to see what's even available and relevant, but in a good kind of precise way based on what's called the sequencing. So sequencing of your tumor is basically like the fingerprint. It's like the blueprint for a house, right? Like architects basically make a blueprint and then they get paid a lot of money to continue to resell that blueprint, because even though you can see it from the exterior and interior, you don't know a house and its bones and everything until you've seen that kind of stuff. And that's what tumors are with sequencing. How can you take the specific type of cancer that you have, all those hundreds of different mutations, not just the fact that it's colorectal, and then also be able to see what is out there, either from academic centers or pharma, and what's the NCCN like common like first, second, third line, what are the recommended ways to do it? That's what XCures does. So that's how we met. And then XCures like, hey Sanjay, love what you're doing. Like keep teaching about these things so that people can understand why they aren't getting certain therapies. But they try to do that as well. It's a free service where you can get basically, you just type in your name and then they populate all of the, like they pull your sequencing, your imaging, the treatments you've gotten, and then tell you everything that's available everywhere. And I think all of this is just, you don't see many people kind of picking their heads up and able to just say, hey, we have a problem here. People aren't getting standard of care in the country. People having to fly like to multiple centers, and obviously cancer is debilitating enough. And finally people are picking their heads up like you, like the telehealth world and Mika Newton, who started XCures. And now I'm getting a little emotional because I never get this like real when it comes to like on a podcast. It's usually kind of on the surface, but it's an amazing thing because like finally people are saying like, let's pick our heads up and innovate and revolutionize, and it's people that have deserved that for a long time. Especially, gosh, I'm rambling so much. I'm sorry, but especially I worked at the VA for a while, and that place especially. I mean, there were so many patients that didn't get there when they did get in with behavioral and mental health, at least in down Louisiana, like it was very good. But then sometimes it can take a while, and there's level of services. So I do think obviously anyone that's worked in the system knows there's a huge disservice to veterans, especially when you talk about the Vietnam vets and stuff. It's just almost kind of swept under the rug. And I'm sure there's something out there where we're able to reach, them more to kind of finally, it's never too late. Some people just have buried it, but I think quality of life wise, just intervening even now could be really impactful.
It definitely can be. That's the beauty of, if you want to talk about specifically mental health, the beauty of that is it's so easy online. You can just Google it, right? No, PTSD, trauma therapy, war therapy, veteran therapy, whatever. And you'll find the companies. And a lot of people say, well, how do I know what's a good company? Well, the interesting thing is that with all the rules with Google and search engines, to even get your website, your digital health website on the internet, you have to pass a huge battery of tests and hurdles and approvals. And Google really, and the other search engines, they won't really put your website up unless it's legitimate. They verify it
Really?
first. Yes, they do. Especially if you're advertising that you're medical care, you can't even do Google ads or SEO or anything like that if you're not doing it right. They will shut you down like that. So
Huh.
the simple fact that you can find them online actually says a lot about the legitimacy of what they're doing. But you can actually, just like a directory, you can scroll through and look for the right person for you, whether that's gender, demographic, life experience, area of specialty, and you can hand pick somebody and usually get in within a week or two, as opposed to 6 months that it might take in the brick and mortar and institutional healthcare. You can
Right.
get in pretty quick and establish yourself, even as a veteran. There's a lot, a wealth of therapists and people out there who want to help the veterans and are trying to find them, but they're stuck deeply entrenched in the VA system, or they'll have TRICARE for life and they still try to go to the Army hospitals or the military hospitals, and they're like the last ones in the door because
Hmm.
they also have Medicare sometimes at that time. But yeah, it's out there.
That's awesome. I mean, it's really neat to know that like it's more or less been, vetted to a degree and that it's accessible. So to that point, that reminds me, like with Christmas and Christmas gift giving and stuff, what if you had somebody that you really cared about? Because obviously the most challenging thing, or arguably one of the most challenging things about mental health care is to get someone to like take that initiative, right? And so if you wanted to gift somebody with like a session or, maybe a weekly session for a month just because you care about them and love them, is there a way to do that when it comes to like HIPAA stuff and health stuff? Like, can I just log on and say, hey, I really care about you. Thank you for serving our country. We've gotten to be friends. And is there a way to do that? Is that a thing? Or I bet you're putting a pencil in it to just make another multi-million
Kind
dollar company
of,
later.
but not really. No, I mean, because if
Okay.
you think about it, it actually happens a lot. So back when I worked at HIMSS, it was very common for women to log in and try to get surprise Viagra
No
for their
way.
spouses. Uh, well intended, right? But the problem is you can't legally, because all the same rules that apply in person also apply online. So if you think about the fact that I can't show up at a visit for you and say, I need Viagra for him, can I have it? You can't do that. But what you could do is say, hey, Merry Christmas. Take a screenshot or download the app on their phone, something like that. Merry Christmas. I'm going to sign you up for this, or take a little video of yourself like, hey, Merry Christmas. I'm going to sign you up for 6 sessions because I know you're hurting and life sucks, and Merry Christmas.
Yeah.
There's a lot of ways to do it, but actually it makes more work for you. It makes more work for the company because they have to delete the whole account and make a new one if you try to sign up to gift it. So it's better just to give the idea and not the actual account, because then you violated
That makes sense. So would
medical
you at least
record laws.
But so you being a mompreneur, that would be nice to have a company, and maybe we can like post a link if there is one for a mental health thing where you can actually just buy like a gift card. So like that way you're actually bypassing, you're not actually making an account, and then you can say like, hey, here's a way to be able to gift for our like behavioral therapy or like mental health therapy, and then you can just populate that kind of gift code card or whatever. So that's if we find something, we'll post that in the podcast because that's pretty
Let's look
cool.
into it. I'll look into it after this and we'll see what we can find. And if not,
Perfect.
I will reach out to some of my friends in the mental health industry and be like, hey, have you ever thought about gift cards?
Yeah.
Because it can't be that
No,
hard
I
to do,
think
right? A lot of them are Shopify stores underneath. So
right. That's true.
on the front
I
end,
think by
a
I
lot of
think
them
by
are
you saying
Shopify
asking
stores.
your friends, you mean you're just going to start another company and just basically crush it with that concept.
Love it.
If there's anything else relating to cancer that you want, so like we have a predominantly like we have people that are very like cerebrally like vivacious, like they love like technology stuff and like how we're moving forward and what we're more aware of. But the big questions that I don't get a lot of, or don't have a lot of answers for in my oncology training is what can I do? Like obviously, like the smoking, everyone says the same stuff. Don't smoke, drink as least as you can. Unfortunately, I've always looked for literature to say that like, oh, in this instance, okay, but in general, alcohol does increase your chances, albeit not, crazy depending on how much you have. And then greens and all this stuff. But is there anything else that you would like people to know when it comes from a preventative care standpoint relating to cancer, relating to like preventing cancer, or you had mentioned a couple of tests with circulating tumor DNA. If you want to describe that, just anything that you're passionate about when it relates to oncologic stuff.
Oncologic stuff from the point of view of a family medicine doctor.
Yeah,
Got this. So
you got it.
I do like the cell free DNA. I don't know what you call it, but the clients that I've worked with, they call it cell free DNA,
Mhm.
which is, as I understand it, they take a sample of your blood and they're looking for certain fragments that have been associated with the likelihood of developing certain tumors, and it can be lung, prostate, gastric, pancreas, breast, if I remember the
It's like
last
30 of
time.
them, 30 to 50 of them. Yeah.
Yeah, several. Quant Gene is the name of a company that comes to mind. And the really interesting thing about it is that it tells you whether you do or don't right now, but again, it doesn't tell you in the future. So and definitely does not replace the routine screenings that you should do. So it's kind of like a Let's Get Checked or a 23andMe, where you're getting it for your own knowledge and edification. But even if it's positive, you would still go see your doctor,
Oh yeah.
because it doesn't mean that you have a raging pancreatic cancer necessarily. It just means there's something about you that has an increased risk, and maybe go see your doctor. I
Well, it
do
would be
think that
risk.
in the
It's either going to be
future,
risk or it's actually going to be the cancer itself, though.
it
Because
can
like
be.
they look at, so they had a big study in China, a big study in Europe, and a lot of these, just like we were saying, like a tubulovillous adenoma, right? That's closer to cancer. So like you may have a mutation that could be in either one, but then it can definitely tell you like if you have things that are pretty classically, iconically only seen in cancer as well. So obviously you definitely need a professional if like it's positive for something. If it's negative, it's pretty, like sensitive to a degree, like sometimes arguably more than screening, because the whole concept is, DNA of cancers, just like your regular cells, everything sheds, everything dies, everything grows. So when things proliferate, the old ones die, and you can kind of see that stuff because the blood, system, fortunately, is closed, or ideally, which means everything circulates like through every single part of your tissue. Like that's how you get your fuel and your gas and your nutrition, and so you're catching those pieces basically, and I do think it's going to be the future, and it's going to help cancer rates like crazy because any cancer, doesn't matter what it is, the best thing and chance to be able to catch it is catch it early enough. If you ideally caught it when it was one or two cancer cells, rather than the 250 million that's required to just see it on a CT scan as a little like 5 millimeter lesion, like then obviously you cut out that colony. That's why with like lumpectomies and mastectomies, we take out the cancer and or lung or anything else, and you take out a whole bunch of stuff around it to say, let's just very liberally make sure we got that rogue colony that just started growing and a whole bunch of good stuff around it. That's the whole concept of margins. But that's a very good point. That test, there's a bunch of them. They're like $800 or $900, I think, in general. And the studies show that there was like basically it was a family medicine or internal medicine doctor's call that they said it's like a mild to moderate, like meh, maybe they have cancer. I can't explain why they look like low energy, why they're losing weight, but everything's mostly negative. It wasn't really crazy like concerning or alarming symptoms that made the test in the study. It wasn't like they had 40 pounds of weight loss or anything. It just was kind of like just what do they call it, physician's kind of like judgment call, and it was actually very sensitive to if they had cancer, it was like found, and then also when other modalities said they didn't, it actually found it. It's pretty impressive science, and I think it'll be kind of a standard over the next 5 years. I mean, it's crazy.
I couldn't agree more with you. And yeah, it also makes me think another thing you can do, like you said, tell me anything about cancer prevention. A lot of times some of the genetic tests, like the BRCA testing, or I forget what the Lynch syndrome one is, where you can get tumors everywhere.
Hmm.
You may not necessarily meet criteria for getting that ordered and paid for, but there are ways out there to go and pay cash for it. If you don't meet criteria to have insurance pay for a BRCA test for you, there's companies out there where you can say, look, I just want to know. Here, take my cash, test me, and you can actually find out that that's actually if you Google on the internet, you'll find there was a lot of companies that got in trouble for trying to use insurance reimbursement for that, and they committed a lot of fraud, waste, and abuse. And some
Mm.
of them are in prison because they like billed for genetic tests that were not medically necessary. But the way it works in the United States of America is that if you want to pay your money to get tested for something genetic, you have the full democratic right to do so,
Love it.
regardless of your insurance company. So you can get tested for whatever you want, really.
Right. And they're finding people that have BRCA like we're learning kind of recently in the last couple of years that like there you could still be in your 60s and 70s and have a BRCA mutation related cancer. So like our guidelines keep kind of widening, right? They become more liberal because at first we're like, oh, if it's not this, that, and the other, and we're like, oh, hold the phone, maybe like if it's any triple negative, or maybe so we're obviously like oncology is a very humbling field. Medicine is also, and but especially oncology, we learn things, sometimes the tough way and sometimes whatever, but it's always changing. And so it's never, a bad idea to exactly your point. If you have, I still use gut feelings as part of my practice. Like it's never going to like completely make a thing, but I do believe that there's something about gut feelings and this and that should be considered. And I believe totally anecdotally in my own opinion that if somebody's very dismissive about gut feelings, I think not only if that upsets you or hurts you, that it's, justified. It also has a big bearing on what the quality of life looks like should certain events happen or not happen. Because if you don't pay attention or respect that gut feeling and something were to play out, if it would have happened either way, this family still thinks to themselves, well, I knew or I thought or I whatever if we would only have. And even if the outcome would have been the same, but you listen to that gut feeling, you have now like basically liberated them from having all those thoughts. Like those aren't actually liabilities that you have to worry about. And that's something that sounds almost silly, but I think has a huge implications because I still see people sometimes that still have a bitterness. I just think if we would have X, Y, Z, and that's a mental health quality of life issue. So please voice your gut feelings. I hope nobody listening to this is ever shy about like something on the tip of the tongue or the second or third visit, especially you want to share and you don't. I'm telling you, a lot of it, and you can say this, I'm sure you feel the same way. Doctors are in very much like to see your children, you have to be very, like, kind of efficient during the day. That doesn't mean you don't care. It's just that's the level of efficiency to see your kids for the most part in the community. But when somebody speaks up, it's like you see the humanism. I want to believe, maybe it's naive, that most doctors will just freeze and you will see a different version of them when you kind of like just, share that thing. And if you don't, then you could see someone else, especially virtually, because you deserve that as a patient.
I have a story. I have a story that highlights that. If we have time,
Please.
do you have time for a
Yeah.
story? This is a really sad story. Actually, it has a tragic ending, but I'm going to tell it anyways because I think it's relevant. When I was in the Army, there was a 32-year-old Apache pilot, and he had symptoms of acid reflux. He was 32 years old, had symptoms of acid reflux, and he was in the Army, so he did what he was supposed to do. He went in to tell people because when you're flying, any sort of bodily distraction is a problem. So instead of sweeping under the rug, he did go in to be seen, and kind of heard the whole, you have ulcers, you have reflux, tried all the treatments, and I think it was 6 or 9 months, and it was the wife who had the gut feeling because he was losing weight and he was having appetite problems and early satiety and some of those weird things that we hear about in school, and it was him that was like, I just have to go to my visit and get my medicine and not have reflux and go fly the helicopters. But she was the one who had the gut feeling, and the way that she would tell the story, as I recall, was that they tried to speak up, but they didn't really feel like anyone was listening, and also they kind of felt like they couldn't speak up because in the Army the culture is a little different.
For sure.
Eventually there was a diagnosis, and it was gastric cancer, and it was stage 4, and it was one of the, so I met them in the ICU, and by that time he was very jaundiced and just had very much ascites, and it was tragic. But what I learned from them was exactly what you said, which was that acid reflux in a 32-year-old is not always acid reflux in a 32-year-old, and it is so important not only to listen but also to say it, and to say it loudly, and to say it repetitively, and to say it without shame and without
Hmm.
fear of upsetting the doctor. Like, heads up, medicine is actually a service profession.
Yep.
Doctors have a
I always say
responsibility
that.
just like a car mechanic does, or a server at a restaurant does, or a flight attendant on an airplane does. And that's to serve you and to listen to you and be nice to you and to be empathetic and to do a good job at the thing they're supposed to do, which is listening to you. So don't
Yeah.
feel bad about upsetting them. And if they get upset, find another one.
Love
Soapbox
that.
in the corner.
Oh, I love
I have a
that. So
soapbox over
refreshing to
there.
hear a physician say that. I mean,
You know,
we almost feel wrong to say that out loud sometimes, but it's just, I mean, it just breaks my heart when someone, you know, doesn't feel that kind of like reception. That's why like on, when I post on social media, it's to make people feel more comfortable with their cancer diagnosis and why they're getting things. And when I hear like I just never felt, it just breaks my heart. And you are part of the way that people can actually have another option. There's a long time when there was no option. It's just bad luck. If somebody was oversaturated or somebody physician may have depression or maybe they are just mean, but I hope not. But maybe like, they're definitely out there to mean people of any
sometimes they
profession.
are just mean.
Yeah,
Let's
but
be
whatever it
honest.
is, there was no other option, but there are alternatives now. And if you don't feel that level of being seen, as they say, then, then if there was a bad outcome, then it's compounded with, well, why didn't I switch? Or I knew they weren't listening. When really, again, if the outcome would have been the same, like you still now have to live with that extra element. And I think the world gives us enough challenges that are, difficult enough when I always see people get super strong. But that's your insurance for the future on being able to vocalize, listen to your gut, make that change. And you said it in the best way. Again, I keep saying the same, redundant phrase, but you nailed it. I think it's, an important point, and thank you for sharing that story. That does tell me it's one of my biggest soapboxes ever is if you are, and even if you're, if you're not postmenopausal, but especially if you're postmenopausal or you're a male and you're anemic. First of all, anemia full blown. You weren't anemic before, bro. You got to figure that out. You got to see like is it bleeding? Do you have
Go.
a bypass surgery? Celiac
Yeah.
disease? But then even before that, if you see like that you're anemic, meaning your red blood cells, hemoglobin, hematocrit are low. Even before that, if you see your RDW, which means like the variation in red blood cell size, if it just all of a sudden randomly starts getting bigger, and then your MCV, which is the size of your red blood cell, starts getting smaller, and it was never like that, and you haven't changed your diet, and you haven't gone on this paleo, not eating any kind of iron thing or nothing like that, you need to get it checked out. Because some of the earliest tip-offs, which is why I consider a CBC once a year a screening test, because if you see that, you're like, bro, am I bleeding somewhere? And then I see so many stage 4 renal cells and bladder cancers and everything that I show my residents that I'm teaching. I'm like, now let's just pray that we didn't see like evidence of this, and you see normal hemoglobin, normal, and all of a sudden you see the changes, and I'm like, they probably had renal cell for 2.5 years.
Oh,
And I
I
hope anyone
hate
listening to
that.
this, yes, all the time, and like and gastric, and GI and all that stuff. There's so many things. And the last thing though is also in gastric, we haven't come a long way. If somebody's listening or someone's lost a loved one, immunotherapy is a very real thing. We're starting to look at that, especially if you have something called a high PD-1. You can have pronounced improvement. I had a patient on a trial, and now now it is standard that you can get immunotherapy, which is not chemo, if you have a high PD-1 score. And then they're also looking at HER2 positive, which is the same thing that's in breast cancer. So I just have to include that. And again, you'll find out all those things if you go to XCures or if you do sequencing with any company. Just you need to be educated, and I try to do that on my social media. You do that everywhere, and now you're definitely somebody I just admire and want to kind of take after on those kind of things because you're very inspirational, Dr. Purdy, and a veteran, and all the things that you've done. I've been very humble to speak with you. I will be kicking myself tonight for talking so much because all I wanted to do was listen. But I talk a lot when I'm excited, so I'm sorry.
New best friends. I don't care. I had a blast, and I'm sure we'll talk again soon.
Yes. Anything else you want to leave with us so we know where to find you? You do virtual like consults yourself. If somebody wants to have this in person about their own health, they can actually see you
Yeah, you can.
on your website.
Yeah, there's a little button that says like click to sign up here, become a patient. I have a virtual primary care clinic that I run. We can do labs and things like that. So now, forever and ever and ever. Actually, I may send out a blast to my patients talking about screening CBCs and see what we can
That would
find.
be great. We can
'Cause I
collab
can
and do
do
it.
whatever I want. This is America, right? So I can order CBCs if I want. And
Democratize stuff.
that's right. And but really, it's great. And even if I don't do the thing that you need, right? Because I'm not a mental health practitioner, I can't do therapy, I can't do counseling. There's a few things that I am not great at, but
Yeah.
I might know somebody who is, or a company that does. Like I personally don't, I can't take insurance. It is cash pay. There's a whole nother story that we could have a whole nother podcast about that I can't. Would not be appropriate to talk about today. Is the reason why I don't do insurance. So I'm cash pay right now, and And so that's not a good fit for some people, but I can help you find a place that is, or refer you to somebody who does virtually so that you can still get the care that you need. It's out there. You just have to know where to find it.
Yeah, no, I mean, like I was saying, like the cash models, just depending on your setting and your community, they make sometimes a lot of sense, and they're actually like sometimes, arguably, again, depending where you are, what's your insurance, like just sometimes better care, sometimes more time, and it's becoming a popular model. I was alluding to this stuff earlier, and since coming out of into practice at a fellowship, a lot of that bureaucracy and red tape, which I think hopefully overall means well or fail stops, but they do get in the way sometimes of medicine. And I think any physician in any specialty like would admit, and share that. So we do the best we can in the system we can. And I love what you're doing to be able to make yourself accessible with, none of those hurdles. That's how also one of my tips about recognizing or knowing a good doctor is what you said. You're like, I can't do this, or I may not know this. That is always in my book like somebody that's a good doctor. You want somebody that knows their lane, that can like understand things they do. I don't have any mental health training. I see it like just anecdotally in the rooms, but that's just kind of a side tip I give my friends, especially that are in other states. Hey, what do you think about this doctor, this, that, and the other? I'm like, when you hear those kind of terms, it's a doctor that just feels very like knows very well what they know very well, but also knows when to ask for help. That's why they call it practice, right? We're all learning, and I think that's one of the coolest things you as a physician, no surprise, was sharing at the end of end of our talk, which I'm so sad is ending.
So sad. But hey,
Yeah,
there's always more podcasts, right?
that's it.